Welcome back, and great to have you after this lunch for our next session. I'm Oliver Hartwich, I'm the Executive Director at the Initiative, of course, and it's my great pleasure to chair this next session. But before I do, I want to thank a few people. Well, first of all, I have to thank, of course, NIB for once again sponsoring this Health Innovators Summit. It's our second one. We had one last year, of course. We thought it was a great success, but today is even bigger. And I want to thank in particular those couple of people standing over there who've actually made this possible on a logistical front. Without Michelle and Chelsea, this wouldn't have happened, so I think it's worth an applause. Thank you to you both. And now to the topic of the session. We at the Initiative believe that policy is really important, but policy is meaningless if it is not helped by data. And we think data is crucial when you want to translate policy into action and when you want to figure out what works and what doesn't. We at the Initiative have used data for a long time, not in health, I should say, but in education in particular. And that was, of course, also Eric Crampton's genius, actually, that led us in this direction. So data analysis is crucial, otherwise you will be like lost at sea without a compass. And so we're fortunate in this country to have an organization that is innovative and that uses data to figure out what projects work. The clue is actually in the name of that organization. It's ImpactLab. It's a data lab, but it's actually there to measure impact. It's to try to figure out what interventions work, what policies work. And we're fortunate today to have the CEO of ImpactLab with us, Maria English. Now, Maria has a high-flying career in consulting. She has a politics and philosophy degree from, I believe, Cambridge and some other universities. And you've got an illustrious career too, interesting to mention it all. But crucially, you have taken over this CEO position as your first CEO position at ImpactLab, working in one of the most unusual companies, not just in New Zealand, but in the world, working with data to figure out how policy works in practice. And you were fortunate, of course, to work together with a very strong team and a very strong board and a very strong chair. And some of you in the room might even know her chair because she was a speaker at the first Health Innovators Summit last year, certain Bill English. And actually, I always wonder how that CEO-chair relationship works in your family. But today, we've invited you to talk specifically about health and specifically about a case study from your work, actually, where you're working with another organization that you all in the room know from at least last year's Health Innovators Summit and, of course, from this year's as well, and that is Ngāti Oroke. So with that, and without further ado, please welcome Maria English.
Tala Falava, Manuia Leaso, Tēnā koutou katoa. It's a real pleasure to be here. And can I please particularly start by acknowledging Rangamaria Hunia, who I don't think she's here yet, but she has been the driving force both behind NIB Toyota that I'll be talking about today, but also this project to really put themselves to the test of trying to understand the long-term social impact of this model. Also Rob Henning, who I think has been an incredible partner in this work. When we started this project, he said it's one of his, this model and understanding the impact of it was one of his top priorities as a CEO. And he showed that. He came to every session pretty much that we did. So Rob and Rangamaria have really been behind all of this. And then, of course, the team who do the mahi in the community at NIB Toyota. From the ImpactLab team, Mari Tanioka, who's here today, who's led the analysis, and Shabini Mahanaraj, our research analyst. So I guess I'm the one with the most free time of any of those people, so I get to talk about all the hard work they did. So to start with, I guess at ImpactLab, our goal is to help make investment work for communities so that people can live the lives they choose. And so far, we've measured the social impact of over 250 health and social initiatives impacting over 800,000 New Zealanders. And there's something that I would say is the most important thing that we've learned so far. And that is that the best health and social services that we've seen, though they're very diverse in a lot of ways, do one thing in common, which is that they don't just help people, but they empower people to form aspirations for their own lives and those of their families and to go after them. And I would say that's the ultimate form of localism. But what we're also learning is that while that's something that's very easy to talk about, it's actually very hard to do, and to do consistently and to do at scale. Inabi Toiora is, I think, a really good example of actually doing it. It's a model of delivering healthcare that puts choice in the hands of whānau, and it gets the system working for them, rather than whānau having to work to fit within the system that is so often not designed to meet their needs. As one member of the hapu told us, he said, under the public health system, I got a lottery ticket. Under Inabi Toiora, I get a choice. So the model's now been operating for 6 years, and it's scaled to reach 3/4 of the hapu members at Ngāti Whātua Ōrākei. And basically, we got the privilege of being involved with this because NIB and Ngāti Whātua Ōrākei approached us earlier this year with a really important question, which is, okay, we've put 6 years of blood, sweat, tears and funding into this model. What is the impact that it's having for whānau? And critically, not just from a clinical point of view, but in terms of their lives as a whole. And how can we use the information about the impact we're having to make the service and the model even better and do even more good for the hapu members? Like a lot of organisations in the healthcare sector, and maybe some of yours, Inabi Toiora team faced a challenge of having almost too much data, lots of data floating around, but they really needed more clarity on how to connect that data up to build some kind of view of long-term impact from which they could start to make decisions. And so we've been really privileged to work together to apply our social investment or social return on investment framework to explore the impact of this model. And I'm going to share what we learned. And I guess it's interesting in two ways. One is how do you measure the social impact of this kind of thing, which is pretty hard to measure. But also, what did we learn about the impact of Inabi Toiora as a healthcare model? So up there you can see the mission of Inabi Toiora. So it's really part of the broader mission of Ngāti Whātua Ōrākei, which is for whānau to live happy and healthy lives and actually not need, hopefully, as much healthcare because they're happy and healthy. And a key part of that, as we heard in an earlier session, is mana motuhake, the ability for people to choose and be in control of their own circumstances. And the hapu felt that this just wasn't happening within the kind of health system as it existed. And so they created Inabi Toiora to radically disrupt that. And really create a different model that aims to achieve not just better health outcomes, but also better life outcomes for whānau. And we kind of knew pretty much as soon as we heard that mission statement that this project needed to involve linking up health and social data, which is something I think doesn't happen nearly enough in Aotearoa. And that's really for two reasons. Firstly, the social circumstances that people are in are really important in terms of understanding barriers to accessing healthcare, needs in terms of healthcare, and to getting outcomes from that healthcare. And on the flip side, when people are healthier, it positively impacts so many other domains of their lives. And the value isn't just to their health or to the healthcare system, but also much more broadly to all aspects of life. And that's something we wanted to at least start to put some real data behind. So the core model of Inabi Toiora, while the thing on the label is the comprehensive health insurance policy, it's free for hapu members and it includes primary care, specialist care and major surgical and medical treatment. But as was alluded to earlier, the magic sauce, as we call it at ImpactLab, of the model is really driven by the integrated support that sits around that insurance and allows the scheme to operate effectively to facilitate what's intended to be really barrier-free access to quality and timely healthcare. So you can see on the right those key components, and they're all equally important. So the first is the navigation and outreach. So there's kaiarahi navigators who are really working to reach out to people, build trust, understand their health needs, and then connecting to them to the right support. And that can be a really proactive process. Like, for example, an NIB kaiarahi might support someone who's got a tumour and they'll ensure that that person gets the specialist care that they need. They don't assume it's going to happen, they make sure it happens. The second aspect is quality provision. So the NIB Toiora team are piloting something called Tohu Toiora. with 100 first choice network providers, where basically providers can meet criteria and get a tick to show that they actively promote a culturally inclusive environment for Māori. And that's really to ensure patients have a positive experience that encourages them to keep engaging with their healthcare provider. So it's not a forcing people to do things, but it means hapu members can see that tick and then they can have a choice with more information about who they might want to go with. And then finally, we have the health management programs and services. So that is a range of health management programs that sit within the model. For example, there's a 21-day diabetes care program, which is all about kind of, the behavioural stuff, diet, lifestyle, learning how to manage your diabetes, and also personal coaching around your diabetes management. So a lot of the stuff that is hard to fit within the kind of traditional healthcare model can happen under those kinds of programs. And of course, that's all enabled by Ngāti Whātua Ōrākei's investment in the program, as well as the data they collect to understand how it's working. And I think that investment is really important because the big question of this project is, well, what's the social return on that investment? What are we getting for that funding we're putting in? So in terms of who uses the model, there's about 5,300 people who are enrolled. And really it's designed to be something people can benefit from across their whole lifetime. So I guess, you want to get people to engage young and then get the maximum benefit, but then they actually have access to this throughout their whole life. And we decided, therefore, to kind of look at different cohorts based on stages of the life course. So mama and pepe, tamariki, rangatahi, the young people, pakeke, the adults, and then kaumātua, the older people. We also noticed that there were some really big differences in how people were engaging with the model, so we also segmented by engagement level. So enrolled only, literally people are enrolled but they're not making any claims. Light engagement, which was people accessing GP and prescriptions, and then deep engagement, which was more specialist care, dental care, and other things. So I'm going to talk a little bit about how we did the measurement, and then I will talk about what we found, which is the good stuff. So at ImpactLab, the way we think about measuring social impact is we try to estimate something called social value. And the idea is basically, if you think of that dotted line as the pathway of someone or a whānau's life over time, it has ups and downs. And then at some point, that person or whānau comes into contact with a program, a service, and really at that point, the opportunity is to shift in a more positive direction, the pathway that that person's life takes. So the difference between what we would expect the pathway to be like without support and how that can shift in a more positive direction is what we call social value. Now, of course, as the data people and the clinicians in this room will know, this is hyper simplified, but that's like conceptually the question we're trying to get at. So how do we actually start to put data around social value? We do it by linking three kinds of information. First, frontline experience and operational data. So in this case, we looked at a few things. We looked at operational data from NIB about what kind of claims people are making, data from Ngāti Whātua Ōrākei about who's enrolled, what are their demographics, what is their experience. And also we talk to the frontline team because they know best how things happen. And in this case, we also got the NIB Tuora team to interview whānau who are enrolled to get a more qualitative view of their experience. Then we looked at government administrative data, particularly from the IDI, the Integrated Data Infrastructure, to see if you can make positive change, what are the flow-on costs and benefits to the system, as well as to individuals and whānau, and their income and the things that show up in public data. And then finally, academic evidence. I think health is an area, unlike most of the other social sectors we look at, where it's actually evidence rich. And the problem isn't so much a lack of evidence in a lot of cases, is that we don't use the evidence we already have. And so that's what we focus on. And so we do that to look at how many people are engaging and how deeply are they engaging, what's the opportunity based on their need, what are the outcomes that can be created, and then how effective do we think this model can be at achieving those. We can go way more into the measurement and the Q&A if people are interested, but I'll leave it there for now. So once we've calculated the social value, combining all that data, we can then divide it by the cost to get to social return on investment, or for every dollar that goes into this model, what's the value we can estimate is returned to Aotearoa in terms of avoided future government cost, family income impacts, and subjective improvements in people's well-being. Okay, the good bit, what did we learn? So first of all, first thing was just looking at enrollment. And what you can see here is that about 3/4 of the hapu are enrolled. But there's actually some really interesting opportunities because 41% of pepe were unenrolled or are unenrolled. So big opportunity to increase enrolment across the board, but particularly for pepe and particularly in relation to the early intervention opportunities that the model has. Mama, by the way, were really hard to identify in the claims data, and so we weren't able to look at that. Then the next level is, okay, let's look at the people who are enrolled. How are they engaging? And I like to think of engagement data as the ticket to the game, because no matter how amazing a health service is, if people aren't engaging with it, you could have the best service in the world, it'll make no difference and probably cost a lot of money. So it seems simple and it seems obvious, but it's critical. So some interesting things we can see here. So yellow is deep engagement, orange is light engagement, and dark blue is enrolled only. So you'll notice that engagement deepens, unsurprisingly, as people get older and have more health challenges. You'll also notice the light engagement group's pretty small. So what that means is most people, once they get on the scheme and they start using it to see the GP, they actually inevitably tend to start using it for other things too. So once you're on the bus, you're on the bus. The opportunities here are interesting. So one is to turn the dark blue orange. Get the unenrolled people engaging because those are probably the people who aren't going to the GP on a regular basis because they're healthy. But actually, if they were, they could actually be getting sort of preventative healthcare and be identifying issues early. And then the other opportunity is to turn the yellow orange as well, because over time, if the model works, we should see people needing less specialist care, particularly in the younger age groups, and being able to kind of deal with their challenges or opportunities more in that light engagement primary care space. There were also some really interesting differences by demographics, like older men were really under engaging compared to older women. So then we looked at what services people access. And this was interesting because pretty much the top claims were similar across all of the age cohorts, which we didn't expect. So the big ones were GP, dental cover and prescriptions, and then a few differences for different ages. We were particularly surprised to see that for tamariki and pepe, the dental and GP claims were really high, even though both of those services can theoretically be accessed for free in the public system. And we did a little bit of digging on that. I think there's more digging to do. But basically, what we found is that even though theoretically those services are free, in practice, there's real access barriers to accessing them, like really long wait times, particularly for dental. There's a limited number of contracted clinics, and especially if you're in a low-income area and you can't afford the transport to get to the clinic that's registered, it's hard. And also negative cultural experiences that whānau had been having with some of those services. So basically, our interpretation is whānau are voting with their feet, and because they now have the choice, they're using that to access pretty essential primary care for their kids that they otherwise wouldn't be getting or they'd be getting much later. So basically, we were able to map out a whole bunch of logic to then evidence a whole set of outcomes, and 12 in particular that we could value. It's important to say there's a lot of outcomes we can't value yet or maybe at all, but there's 12 that we could. And you'll notice that a lot of them are healthcare things like, for example, reducing hospitalizations, reducing ED visits, improving physical health. That's, by the way, that's a subjective measure. That's why it's broader. But there's also a lot of social outcomes in there. So, for example, increasing academic achievement. So, there's kind of a lot of evidence connecting healthcare for kids to their academic engagement. For example, studies showing that when students who have low levels of access to paediatric care, they tend to be the students that also have lower levels of early academic achievement, even when you control for socioeconomic status. So it really is a health impact. And the kids who are affected by poor health and get behind in their academics, it's much harder for them to catch up. So there's kind of a million stories sitting in this data, but the point is that the outcomes are broad and the mechanisms for why we get to these outcomes were also quite a lot, but the three main ones were, firstly, that the model deliberately targets the actual barriers to access that whānau have, in terms of knowing what the services are, trusting what the services are, having choice about what the services are, so that they're more likely to access in a way that's timely and in a way that's preventative. We heard one story from a guy on the model who said he saw his surgeon through this program, and his surgeon told him, well, if you were going through the public system, you would have waited 12 months, and then you probably would have had irreversible heart damage, because the system isn't able to prioritise this kind of issue that quickly. So that's the real direct nature of the problem that's being solved here. We also saw, even though you've got common claim types across age groups, there's 64 different claim types in total. So what you're seeing there is kind of the differentiation you get and the ability to get the specific service to meet a specific need when people have choice. The second mechanism was coverage of pre-existing conditions. So unlike most insurance, this model covers pre-existing conditions, and we know that the greatest burden of chronic conditions is sitting with Māori and Pacific people. So that's really important. And finally, access to culturally appropriate care, as I mentioned earlier. So I won't go into this in detail, but basically, as I said, there's a lot of existing research that we used in the modelling that tells us things that this group already knows but are generally not valued. For example, kids who face barriers to seeing a GP are at significantly higher risk of hospitalisation. So there was a 2022 study, mothers who said that they had barriers to taking their kid to the GP at the age of 2, more than twice as likely to be hospitalised in the next few years. And similarly, vaccine coverage is another one. It's obvious, we know it, but it's still true that the inequitable vaccine coverage for Māori and Pacific women, particularly when pregnant, leads to higher hospitalisation from preventable illnesses. And so then we can look at that logic and we can look at the cost savings to the system of reducing that hospitalisation through better access to GPs. Okay, so what was the kind of final metrics? In total, we estimated almost $10 million of social value created from the program, or the model, I should say, at a cost of $5.2 million. So overall, that's an ROI of $1.90, 190%, which is pretty good. And also just really reassuring, because this is, we've been very conservative in our estimates, and there's a lot of important data missing. For example, the Ngāti Whātua Ōrākei Kaiarahi actually help whānau connect with a lot of other social services like financial management, childcare, and none of that's captured here yet because we're still working on getting the data. So it's a conservative view, but I think a really positive and affirming view of the big call that Ngāti Whātua Ōrākei has made to invest in this kind of model. And then this is the last thing in terms of the analysis, which is mapping all the different cohorts based on the cost per person and the social value per person. So again, the data nerds, we can talk more about this later. But what's kind of interesting is the distinctions between cohorts. And it's kind of the picture you'd expect, which is that as people get older, the social value goes up. And that's really a reflection of engagement. They're engaging more deeply, but also the cost goes up because the services they're accessing are more expensive. But from a kind of SROI point of view, there's not that much variation, although you do see a big jump to the kaumātua group because the engagement level is so much higher. Interestingly, if we take out the people who are enrolled only and don't engage, the picture looks quite different. Mama and Pepe rocket to the top because of the power of early intervention for that cohort. And then you actually see the ROI is higher the younger people are. And that's because it's quite a lot cheaper to serve them, but there's a lot of preventative power in getting them access to the right services early. So it's sort of two different stories, a story about engagement and a story about sort of time point of service interaction. Future opportunities, I think just the big one here is just the power to keep leaning into linking up the data. And in this case, the GP data, the NIB claims data, and the Ngāti Whātua Ōrākei social data. There's a lot of important questions that can be answered that we haven't yet if we can get more of their population data linked up. For example, are the people who have more social vulnerability less likely to be enrolled or to engage with the program? Because if so, we can go find them. Another example, are tamariki who aren't making GP claims but are enrolled, is it just that they're getting those GP visits free for the public sector? Or is it they're not engaged with any GP? Because again, we can find those tamariki and engage them. I think the key difference now for NIB and Ngāti Whātua Ōrākei compared to 6 years ago is that because of this localised model, they can actually act on the answers to these questions. Instead of sitting waiting for someone else to and worrying about it, we can use the data to explore these questions and then use that to make decisions about how the service can improve to best meet whānau needs. That's it.
Thank you, Maria. Yet? Yeah, thank you. Thanks, Maria. That was great, and it was great to see localism in action and measured. And as you said, there are a million stories in all your data, and it takes people like you and your colleagues to just dig them out. We have probably about a quarter of an hour for questions, so who would like to kick us off? Alan Judge. And there's a microphone coming your way.
Maria, if you've got, I'm sure there are lots of businesses here that have a whole lot of clinical data, but to do the work that you did here, you need social data as well. And presumably the IDIs are anonymised, forget that. So can you still do it with clinical data and use the IDI to get other information that might not be patient-specific to do the same kind of exercise?
Yeah, so that's one of the reasons we created ImpactLab, was because we recognised it's really difficult to get the social data. And so we've kind of developed, I guess, a library of values with certain segmentations by ethnicity and so on, based on the IDI, but it is all anonymised. So what that means is you're not linking to your population, but you're linking to a somewhat like population. So that's kind of one option. The second option is, and that's what is the opportunity with Toi Ora, is to actually directly partner with organisations that have that data. So we're increasingly doing work in that sort of data connectivity to link up data really securely. But the advantage of that is, as you said, you can know it's actually the data about these patients, and of course you've got to have the right consent and governance around that. And then I think the third level is, what can you infer from the health and the clinical data? I would say the primary health data with GPs is the best example of this, where it could be utilised much more. There's actually a lot of social insight in that data, but it's not captured as much as it could be. So I think kind of on all fronts, we can know more with what we have, probably.
Any more questions? Roger.
I'll defer to David.
Oh, so kind.
Thanks for a great presentation, Maria. Just a curiosity, the graph or the table you put up with enrolment, I suppose I looked at it and thought, why wouldn't everybody want to be enrolled? I'm just interested in your thoughts around why the lack of enrolment in some of those cohorts. Yeah,
it's a really good question, and I think it's one that we haven't had a chance to explore in this phase of the project, but is certainly something that the NIB Toi Ora team are actively looking at. But I think part of it is some of the reasons NIB Toi Ora was created, which is, the legacy of colonialism, a low level of trust in the health system and maybe health practitioners as well sometimes. So the model is trying to overcome those barriers. And yeah, enrolment's kind of like the first milestone of that. And then the second milestone of that is people actually making claims. But it's a really good question. I know Rob and Rangamati are thinking hard about that.
Eric.
Oh, great. Wonderful presentation. Thank you. When you had the chart showing the return on investment by age, was that the return that's experienced during the age cohort, or that's expected over the future life course because of the change in that cohort?
Great question. It's the change that's expected based on the services accessed during the measurement period, which is 1 year, by people in that age group. So you're bang on. What that means is if you kind of track someone through their whole life, then theoretically the value would add up, right? Because you start off as a baby and there's some value there, but then you move through, and all the way along you're banking value. But on the other hand, we'd expect by the time you're old, if you've gone all the way through, you should be using less. So that would be the kind of souped up analysis, which I'm sure Rob will want to do. And NRB Tauta are investing in their data infrastructure to be able to do more of that longitudinal tracking.
Thank you.
I've got a couple of questions myself. Can you give us an idea how resource intensive your project was? Because we've done work on IDI as well, and we know how long it can take even to get permission to get into the lab. So how much actually did you have to invest? How long did this project take you?
Yeah, so I think in terms of accessing the IDI, it took us like 2 years maybe, because understandably it's very tightly governed, and you've really got to be able to meet the criteria. But in terms of this kind of analysis, now it's kind of a 6-week process for us to run this kind of process on a cohort and an intervention, and that's also part of what we're trying to do is just make it a bit more faster and accessible to do this type of work, which maybe historically might have taken. Well, I know a few examples of this where it's a whole policy team in a government department spending a year to produce that, and actually it doesn't need to take that long, and decision makers need it faster, so we're working on that.
And that's my second question. Is it possible now to build on that work and take your model that you have developed for this particular intervention and use it elsewhere?
Yeah, so that's part of our model is every time we learn something, the next customer we work with should benefit from that learning, because we see a real lack of that in, I don't know so much about the health sector, but certainly the social sector. You read and when I was at Boston Consulting Group, I would read the same set of strategic policy recommendations 5 times over a 10-year period, and it's still the same recommendations, right? But yet we have to incur resource to build out the same recommendations we already made. So I think there's a lot of potential to kind of build on the learning, and that's why we've focused on a fairly standardized model. There's obviously big limitations of a standardized model, but what it does mean is the model gets smarter every time, and we can get better and better at understanding the stuff.
More questions? Yes, please.
You talked about the navigating system, the Navigators being the secret sauce. What would trigger a navigator being connected to a patient? Because that also seems super crucial.
Talk a little bit more about that.
So I've got several questions actually. One is, where'd you get the navigators from? Like, who are they? And kind of what sort of skills do they have? And also, like, how does someone get engaged with a navigator in the system? Yeah,
great questions. Actually, Mari is sitting right behind you. So maybe pass the mic to Mari and she can answer that one.
Yeah, you could just talk to me, but we'll tell everyone. So I know Kayara here sit both within the NIB and Ngāti Whātua Ōrākei side. So within Ngāti Whātua Ōrākei, they're pretty much part of the community. So it makes it much easier for whānau to be able to access. And I guess the ways in which they help is really on multiple fronts. I think going back to the question from the gentleman earlier, really about why aren't people enrolling? And I think exactly what Maria was saying, but it's also about health system literacy. And I think for some people, they've never been part of an insurance program. They're like, what's in it for me? Why would I do this? And Kayara, he really helped to make that bridge, to be able to explain really things that maybe, quote unquote, seem simple to other people, but they really break it down to be like, okay, this is how you benefit. This is how you use it. And they'll take people through the whole process, whether it be, I just had a surgery. What do I do from now? They'll come in and say, hey, I've set up the appointments weekly going forward, and this is the plan for you. And please let us know if you have any issues. And that's just one example of how they support, but they really support in a really multifaceted way, both social and medical.
Yeah. So they personally know the whānau, and they run a lot of events. And we grappled with how to measure that because it's quite intangible, but events that build trust, build awareness, and are a doorway, one of many doorways in.
Anyone else? Roger. Good.
Okay. Fabulous presentation. The $1.90 per dollar spent obviously includes private benefit and public benefit. What's the breakdown?
Yeah, that's a good question. I don't know off the top of my head, but I would think for this type of model, the majority would sit in the public benefit in terms of reduced downstream healthcare costs. because those costs are so significant.
Yeah, so Lester Levy and the Minister of Finance must really love this scheme. Have you argued for a portion of funding?
Yeah, well, I guess that's sort of one of the opportunities of the sort of the SROI analysis when it's built using the actual government data, because of course there's lots of analysis which just comes up with theoretical numbers, and sometimes you have to, but actually there's a lot of real data that I think we should use. And when you do, it really starts to shift how we think about investment and where it's optimal from a taxpayer's perspective, us to make that investment because it's better for the books, but most importantly, it's better for the people.
Eric, again.
I'll take the chance if nobody else had one.
You're the data guy.
Well, it is kind of a data question. So I hear a lot of concerns from people who use IDI that the system always feels like it's about to fall over. There's memory constraints in it. It doesn't seem to be up to date anymore. It has felt as though that's part of the funding environment that they possibly... There's sort of this broad picture of whether central government should be funding stats to have this facility available so that folks like you and others can do this kind of work. There's an alternate view that anybody who's using it should be all on a user fees basis and stats be doing it on a cost recovery basis. What's been your experience in the charging environment at stats? Do you have access? Are they charging a lot for the service compared to the value that users get out of it? Should the government be looking more at funding IDI as a public good as part of social infrastructure? How should we be thinking about this, and what's been your experience in using it?
Yeah, I think it's a really important role government can play is in establishing a really good centralised data infrastructure that enables these highly localised initiatives to access the insight that they need to make decisions that improve services for the community. I think as to where the IDI is at, yeah, I definitely agree. Like, it's clunky, it's difficult, but you could I talk to people in other countries who are still extremely jealous that we actually have it at all. So it can certainly be improved, and you've got to invest to maintain that infrastructure. I think at the moment it already operates as a public good for academic research. Where we want to see it used much more is operating as a public good for policy and social service and health service improvement. And that's why it's so critical that practitioners, like people actually delivering services or making decisions about funding to deliver actual services, can access insight from it. But, you know, of course, and that's kind of what we try to do is be really simple with what we're putting out there. And we don't show the sensitivity range around the numbers, and we don't show the 10 pages of assumptions because, in our experience, decision makers don't have time or energy to read that stuff. What they just need is like the bits that they can take forward and use. So I think we need a good infrastructure, and there's certainly I think that is a role for central government. But we also need intermediaries who can sort of translate that into something that's relevant in a local context. Like, yeah, because what we've found is the people who can do the most with this information are actually often not the policymakers in Wellington, but it's the kaiarahi out in the community who can use this to just get some insight and hone how they're working with whānau.
That said, policymakers in Wellington could probably do more with the IDI. So my follow-up on Eric's question is actually, how much do you think they're actually following your work? We've done our own bit on IDI research, and whenever we presented it to ministers, they were all, oh, this is really interesting, but then it somehow stalls in the machinery of government. What's your experience? Are they watching you? Are they trying to replicate what you've done? Because we had this impression for the last 5-6 years that government didn't really know what to do anymore with the IDI, so they actually took outside organizations like yours to actually show them what their own data could achieve.
Yeah, I think we certainly see that some pockets of the bureaucracy are really receptive to this kind of thing, especially because the insight they don't have is what's happening out in the community. And so when we can link, I think that's important. Like, it's not just the administrative data and the IDI, it's linking it with what the doctors know and what the navigators know and what the nurses know. So in that sense, we've found quite a lot of people really receptive. I mean, we've got an interesting situation in Aotearoa now where, as I said, we've worked with over 250 organisations. We've got small community grassroots charities run by volunteers who know more about the social return on investment in healthcare initiatives than the government policymakers do. And I think that, you know, eventually the policymakers need to catch up, I would say.
Okay. Do we have time for one more question? Maybe? If there is one? Well, if there isn't, then... Oh, okay. Sorry.
Kia ora, ko Carol at Motaka Inwa, Well South Primary Health Network Clinical Director. Thank you very much for your presentation. I'm just thinking through this really brilliant work you guys are doing, you know, from outside health organisations. Just wondering what potential you see for it to be done within health organisations and that kind of, you know, middle-level size, meso-level organisations that, for example, primary health organisations represent. Because there seems to be lots of opportunity, but it's just sort of, you know, where would you see that being?
Yeah, well, I think anywhere you've got natural networks of aligned organisations and some existing standardisation of things like funding flows, services and so on, workforce, there's a big opportunity, right? Because it's much easier to connect the data up and to build a bird's eye view when you've got that in place. And I think not having that in place, it's very difficult to do. So I think the question for PHOs and for other organisations at that level is, what's the decision that the data could help you make? Because if you start with that question, it gets you very focused on what actually do you need to link up and how, and to what level of accuracy do you need to go to help you make a better decision than you would have yesterday. As soon as the data process becomes separated from the decision, you just end up, in my experience, in a black hole of just data and complexity, and it's really hard to see the wood for the trees. So you could end up spending a lot of resource without getting anywhere. And the other advice I would say from what we've seen is you've got to really link up the different parts of your organisation. So we commonly see the operational people don't talk to the finance people, don't talk to the data analytics people, don't talk to the clinical leads. And you actually need you need data from all of those areas, and you need to put it together in a way that makes sense to all of those areas to get a good result. So just getting people around the table together, looking at the same information is critical.
And that brings us to the end of the session. Can I just say that your work is mightily impressive. I hope and I really wish that more people, more departments, government departments would actually learn from what you're doing. And so we wish you every success with your work and you and your colleagues are doing. But for now, I just ask you all to join with me in thanking Maria English.
Thank you.